So our goals for today is we wanted to start by providing a brief overview of our risk screening and assessment process and our rationale for our approach. We wanted to introduce the Columbia tool. We wanted to talk about our expectations, that is the department's expectations of providers in regard to ongoing suicide risk screening and assessment. And then we wanted to just provide some examples that help to show how this tool will be used and what we should expect to see. So I'm just going to go, each presentation that we have had, we've kind of started with these first few slides, and I'm going to go over them briefly just to ensure that we're all kind of starting from the same place. So as we're all familiar by now, Adult Community Clinical Services, or ACCS, one of the most significant changes in this service was really the focus on this being a clinically enhanced service in which licensed clinicians are accountable for all aspects of service delivery. This includes engaging the person and identifying the multiple strategies that the team will use over time to initiate and sustain engagement, how they are actively leading the assessment and treatment planning process, how they are delivering services directly to the individual, and then providing direction, expertise, and supervision within the team. So the ACCS service requires a ratio of clinicians to persons served to ensure that there is adequate licensed clinical staff to deliver services and oversee treatment planning and supervise staff. And the ACCS service also established standard methods for screening, assessing, and reassessing both risk and protective factors, so that this information is collected by utilizing standardized screening and assessment tools and is done in a framework that is trauma informed. So we've had so this is the third of 4 sessions. We have previously conducted sessions on the self-sufficiency matrix and the HCR20. Today is on the Columbia scale, and next week the final session is on SBIRT. So one thing for us to keep in mind as Margaret begins talking about the Columbia scale is that the screening, assessment, and treatment planning process are really dynamic, continuous processes. One does not begin and the other end. They are continuous and interrelated. While the department establishes timelines for when assessments and treatment plans are to be completed and reviewed, what really drives this process is the person, the changes in their symptoms and their status and their environment and their goals in their life. And we really want to use assessed documents and electronic health records as tools that enable us to more fluidly deliver services and treatment. So with that, I'm going to shift over to Margaret, who's going to introduce us to all things Columbia scale.
So good afternoon, everyone. One thing I wanted to just set the stage for right before we get started is that I'm going to do a rapid, sort of very brief overview of a lot of elements of this process. And I just want to take this opportunity to encourage all of you to reach out to me if you'd like more in-depth training on any of it, because we're really just going to be touching on a bunch of sort of hot spots, hot topics. So this first slide sets the stage for why it's important to talk openly about suicide. And what I want to underscore here is, first of all, that the CDC regards suicide as a preventable adverse event. And interestingly enough, a recent survey of the sort of general population found that 94% of Americans also believe that suicide is preventable. And so that's sort of a radical flying in the face of kind of a clinical tradition that has said, at the end of the day, there's nothing we can do if someone really wants to die by suicide. So there's a tremendous effort within the healthcare field to really sort of debunk that myth and work on preventing suicide. What I like about this particular slide is it really focuses our attention on people who are thinking about suicide. The number of people who die by suicide each year in the United States is 40,000. That is a tiny fraction of the number of people that have thoughts about suicide, that develop a plan around suicide, and it's, I think 22, I can't do my math quickly right now, but it's like 25, 250, I forget, whatever. More people make suicide attempts. So our opportunities for intervening are huge. And within the Department of Mental Health, and the reason why we are really focusing on this with ACCS, the number of suicides that people who are served by the department experience each year is between 20 and 25 deaths a year. What that actually represents on the sort of national scale is the equivalent of about 100 suicide deaths per 100,000 people. And nationally, the general population, the suicide rate is 12 to 14 deaths per 100,000. So people served by the Department of Mental Health, and this is true across the country, not sort of exclusively in Massachusetts, but people with severe mental illness served by the Department of Mental Health have a 10 or 11 times greater rate of suicide per 100,000 than someone in the general population. So this is sort of one of those urgent matters that we need to do better on. So in terms of thinking about prevention, I think the first thing we need to talk about is how do we understand why someone contemplates suicide. And the idea is that suicide is an attempt to solve the problem of intense psychological pain. Most people who attempt suicide, there is at least a small part of them that does not want to die. What they are largely seeking is relief from tremendous, debilitating pain. And so our task, when you take together the observation that the prevalence of suicidal ideation is so much more greater than the number of people who die by suicide, when we're talking about prevention, what we want to be able to do is recognize early who are the people that are thinking about suicide and how do we intervene to address the psychological pain and the issues that are giving rise to those thoughts. So let's go on. Before we sort of launch into what is the Columbia severity rating scale and how do we use it, I wanted to just underscore that the whole movement in the field of suicide prevention today is very consistent with the principles and mission of the Department of Mental Health, in that it is completely trauma-informed, recovery-focused, and person-centered. That the only way to work with someone who is in tremendous pain is to find a way to build an alliance with them, to help inspire a sense of hope. It is not to punish people, and we're really trying to interrupt the knee-jerk, call 911, send someone to the emergency room. We are really trying to set the stage, particularly with the clinical competence that we want ACCS to deliver, to do early intervention and intervene long before those drastic kind of therapeutic interfering interventions are required. And so that's why, again, it's incredibly important that the teams are using these tools. So today I think it was a tall order. I'm supposed to talk about screening, assessment, treatment planning, and how it infuses the entire, everything that everybody does all the time. And that is actually how we address suicide risk. And what I wanted to say about this is, first and foremost, we're going to talk about the Columbia in just a moment, but first and foremost, in doing good prevention work is really understanding who the person is, what strengths they bring to the table, what vulnerabilities they bring, and a little bit later we'll talk about some of the psychosocial factors, some of which they have no control over, like gender or past experiences, and some of which are related to modifiable kind of experiences that they're having. But the bottom line is, before you can do a good suicide screen or assessment, you really need to know who the person is, what's going on with them right now, why they might be in a greater state of crisis or level of distress than at other times. So you really need, first and foremost, to know who the person is. And then we're going to be talking primarily about the Columbia screening tool, which is not an assessment tool. It is a set of questions, as you'll see, to use to sort of detect, determine, make a decision about whether or not someone needs a more comprehensive assessment right now, immediately, or within the next day or so. So it's really about just sort of verifying whether or not someone needs a more in-depth assessment. And then a suicide risk assessment is a process that draws on both kind of empirical knowledge that we have about what increases someone's risk and really good clinical knowledge about what's going on with that individual at this moment and how those pieces fit together and help us think about what their sort of level of imminent risk is and what services and resources need to be sort of rallied to their aid. So, what is the C-SSRS? It's an evidence-based, standardized screening tool. There's actually a substantial amount of research that's been done on its use across multiple settings, inpatient, outpatient, schools, health centers. It's widely used both within healthcare and within community settings. It's used by paraprofessionals, lay people, and healthcare providers, both medical healthcare providers as well as behavioral healthcare providers. It's intended to be short, easy to administer, with strong reliability and validity across all the populations. And I think it's, I have to check the age, but I think it's age 12 and up. It's been validated and found to be reliable. And then for our purposes, the reason why we want to use a standardized screening tool is that traditionally in behavioral health, we've largely relied on good instinct and intuition and clinical judgment. And those are all important elements to a good assessment, but particularly with suicide, because of the fact that it's difficult to talk about, people are reluctant. Healthcare providers, behavioral health providers, well-trained clinicians are often reluctant to ask the question. They worry about upsetting someone, they worry that it's not really relevant, etc. And so kind of putting it front and center and saying it's really important to ask these questions, and the purpose of a standardized screening tool is that we all ask the questions in the same way, we use the same language. The intention is to ask the questions, not just infer the answer from sort of looking around and doing what we've always done. The intention is to ask the questions as they're worded so that we're all using a common language. This is a little bit more background on it. You'll see it's a series of questions, and the idea about the screener is also that it's something you might do when you, generally as part of the first time you are doing a comprehensive assessment on someone, and then it is also intended to be used in an ongoing way if someone's status changes or if someone's been identified as at high risk, as a way of checking in and reassessing and seeing whether there's been a change in their status. So it's meant to be not just a one-time only, but a very flexible tool that can be used in the moment as needed to assess whether or not someone needs a more comprehensive assessment around their suicide risk. And as you'll see when we look at it in just a moment, the intention is not to get super concrete and ask the questions as they're worded. Ask additional questions that you need in order to really suss out the situation, and rely on observations and all other available information. This is something I think not infrequently when anyone introduces an evidence-based practice, people get a little hung up in sort of following the letter of the law of the evidence-based practice, as if they have to set aside sort of what they know. The intention with this tool is to continue to know what you know, use all the information available, and ask these questions, and together make an informed, sort of empirically based clinical decision. And then just, the observation that the scale, the questions don't change. What changes are the time frame that you might reference. So you'll see in a moment, the most classic version of the scale is really to look at ideation, suicidal ideation in the last month, and suicidal behavior in the last 3 months. If you just assessed someone last week and they were at high risk, you're not going to ask the questions again about the last 30 days. You're really interested in what's been happening since the last time we talked about this together. And so you can either have that flexibility within yourself, or there are multiple versions of the scale that you can use that give you that flexibility written right into the document. And also, what you'll see, what I'm going to present is the scale and then kind of a triage decision key that's largely for community settings. You may have different responses to given how someone responds to the scale, what your facility practice is, depending on how someone responds to the scale. That may differ from an inpatient setting to an outpatient clinic to a group living environment, or it may differ depending on whether someone is new to you or someone that you know very well and have a really strong treatment alliance with, or someone you know really well and don't have a strong treatment alliance with. Those are all variables that go into kind of how you take the information that you've obtained and use it. So this is a lot of build up to what is the scale itself, but so some of you may know that there's a Listserv called the Zero Suicide Listserv, which is part of a huge national, actually international effort at this point to really change how healthcare addresses suicide prevention in the healthcare systems. And so on the Listserv about a month ago, Susan Steffen, I think people in Western Mass know her. She's a lawyer. She's done a lot of really educating folks about how to manage the risk of working with people who are suicidal while really trying to sort of honor autonomy and shared decision making. So I just want to underscore this point that as she points out, more than 100 attempt survivors of serious suicide attempts have been talking with her. And it's really just the reminder that any screening tool, any assessment is not purely to, we like to say, CYA, manage liability, and check a box. It really is an interpersonal intervention, an opportunity to do a piece of work with someone, for those folks who are in unbearable pain, to offer them a connection and some sense of hope and some perhaps relief or amelioration of the pain. And so she really says, don't ask the screening questions if you don't have the time to really listen and really resonate. So it's not just about getting the job done, it's about really connecting with a person and making meaning. Okay. I think I'm moving along quite quickly, but I'm not. So I'm gonna keep going, we're gonna pick it up. Okay, so here it is. So the C-SSRS, on one hand, it's divided into two parts. So you ask questions about suicidal ideation, and then on the next slide I'll show you the question about suicidal behavior. And this, again, is just for you to get a little flavor of what we're asking providers to do, and if anyone wants more information about the scale or training in how to actually administer the scale, please contact me. But everyone is asked two questions, question 1 and question 2. Have you wished you were dead, or wished you could go to sleep and not wake up? So for many folks, that's sort of an allusion to passive suicidal ideation. Everybody gets asked the second question. Have you actually had any thoughts of killing yourself? That is, we just had a big conversation last Friday. It can be really hard to ask that question. People are really, clinicians, providers, people are really reluctant to use the word killing yourself. It's really important to ask that question using those words. And so that's something just to be aware of, and providers need a lot of support to kind of do this hard work. If someone knows to both of those questions, you go on and ask the suicidal behavior question. If someone says yes to one, they've had passive ideation, but no, they've not had any thoughts of killing yourself, you go on to the suicidal behavior question. If someone says, yes, I have had thoughts of killing myself, then there's 3 additional questions that get asked that look at whether or not someone's thought about a means or method, whether they've developed a plan, and whether they have any intention of acting on this plan. And I think anyone who's been doing clinical work and suicide risk assessment will recognize these. These aren't new concepts, it's really just organizing the way that the information is asked and the way that it's evaluated. So I'm just going to point to the colors on the right. And actually I'm realizing one of them I meant to have changed and didn't for an outpatient setting. But yellow is sort of low risk, orange is moderate, and red is pay attention. And number 4, have you had some intention of acting on them, actually should be red. So let's go on. So you gather that information and then you go on and you ask about suicidal behavior, and I clearly made a, oh, here we go. So the past month at the top of the screen is just left over from the earlier screen. For these questions, you're asking about, have you ever in your life made an attempt? And if yes, have you made an attempt within the past 3 months? And what I want to say here is that when we're talking about, you can look at the language super carefully, but this slide actually spells it out a little bit more simply. What we're actually talking about in that question is, have you ever made an attempt? Have you ever started an attempt and stopped yourself? Have you ever started an attempt and had it interrupted in some way? And have you ever engaged in any behavior preparing to make an attempt? And what's really important about understanding that all 4 of these, I was trained many years ago that there was a difference in terms of level of risk if someone had stopped themselves or hadn't, had prepared but then hadn't sort of gone forward with making an attempt. Empirically, there is absolutely no difference in terms of predicting risk. And so that's kind of a cognitive assessment for some, adjustment for some of us, that empirically any of these behaviors are indicative of high risk. The other thing that the Columbia does, and this is something that sort of more in a more extensive sort of training about the Columbia would get into, is really differentiate between self-injurious behavior and suicidal behavior. So suicidal behavior is behavior where there is the intent to die. The one caveat to that is if you engage, you may indicate that you didn't have an intent to die, but if the likelihood of death is so obvious, like jumping off a 10-story building, actually they probably would have died, but jumping off a 3-story building. So if the outcome of death is so obvious, the intent can be inferred, even if the person is verbally sort of denying it. So this is an example of how an outpatient setting or a community setting might organize their responses to how someone responds to the screening tool. So if they say no to ideation, passive or active, and no history of suicidal behavior, particularly in the last 3 months, they would be considered very low risk. And what's important about that is it doesn't say no risk, it says very low risk. So particularly when you are working with people with severe mental illness, many of whom have a history of trauma, and many other indicators of risk for suicide, they are never not at risk. They may be at very low risk, but you want to keep that in mind. Low risk is if there is an indication of either active or passive suicidal ideation without any elaborated plan. So they answer yes to the first 2 questions, and then they say no, 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 no to everything else. They've never made an attempt, they've never had suicidal behavior, and they've never thought about a method, developed an intention, or developed a plan. And in that instance, if you're sitting in an ACCS, doing an ACCS assessment, you would think about whether or not this person has a treater, and just make sure that if they don't, they get referred, or if they do, just making sure that this is something that is on the radar of the person that's providing treatment. And then you would develop your sort of plan as a team for how often you check back in, and perhaps use the Columbia as a reassessment tool. Moderate risk is, again, either suicidal behavior more than 3 months ago, or thoughts about a method but no intention or plan that's been developed. And so I'm getting into a little bit of the nitty-gritty details here. And then high risk is there's a method that's been identified. There's not only a method, but there's an intention that has developed, or a plan that has been developed in the past 30 days. So even if it's not at this moment, so this is one of those judgments. If the person isn't saying yesterday or 2 days ago, but within the last month, you're going to have a different response to how you work with them, but you should certainly have a more comprehensive assessment. So they may not be hospitalized. In fact, it's unlikely they'd be hospitalized if what they're reporting occurred more than a week ago. But you would do a comprehensive assessment. So I think I'm doing well. Because now we're talking about what goes into an assessment. So let me actually pause there and just see if there's any questions about the Columbia itself, because I think that, and Steve, do you mind clicking on the
So
slide?
everyone is now unmuted. So if you have questions, please feel free to ask a question.
Okay, so we'll just go on. I'm just going to briefly kind of go over, after someone's been screened, the decision is made to do a suicide risk assessment. I thought it might be just helpful to know what we think about when we do a suicide risk assessment. And one way to organize it is around what are kind of the suicide-specific elements that you want to look at. And so this is sort of going back to questions about suicidal ideation and behavior and digging into more details. Right now, how often are you having these thoughts? How persistent are they? Are you able to stop having them, or are they so intrusive that they're constant? So you want to look more carefully at the nature of the ideation. We're also aware kind of the field of practice and research has really tried to cull down and understand how do we identify people, particularly when someone is persistently at risk. How do we figure out whether someone is at imminent risk? There is a high risk that they may act on these thoughts imminently, within the next 24 hours. And there's been a tremendous amount of research that's really identified sort of over-arousal, which is a very physiologically uncomfortable, excruciating state to be in conjunction with kind of a dramatic increase in a person's suicidal ideation. So within their own sort of baseline, has there been a dramatic shift in their thoughts about suicide? And then a profound sort of alienation from sort of the ability to feel connected or gain hope, either from things that are important to oneself or from one's relationship. And so in doing a comprehensive suicide risk assessment, we want to look and try and determine whether those factors that are associated with someone acting imminently are present. Those factors also have the quality of being intervenable, particularly the over-arousal. If someone is so uncomfortable in their skin because they can't sleep and they're having nightmares and they're just so anxious and agitated, we can really try and help them be less physiologically aroused and get some comfort, at least at that level. We look at whether or not the person sort of has the capacity to act on thoughts of self-harm. It's actually very hard to do. And this is one reason why self-injurious behavior, which all by itself is not indicative of suicide risk in the moment, but it is part of someone sort of practicing overcoming that impulse not to harm oneself. And then we also look at access to lethal means. So what access does the person have and what behaviors have they engaged in to obtain the means by which they are planning to take their lives. I'm not going to go into this in great detail, mostly to leave some room for discussion, but this just is an illustration of the original point that I made, that in order to do a really good suicide risk assessment, you need to do a really good psychosocial assessment. And so these are elements that are not specific to suicide. I think if you're looking at our violence risk assessment and risk for other risky behavior, these factors are part of any sort of what puts someone at risk. And so you need to pay attention to these kinds of things. And then I wanted to talk a little bit about mitigating factors. This is, it's not controversial, but we have a more nuanced sort of understanding about this than perhaps we have in the past. So if we go back and look at that triangle of starting with thoughts on the bottom and attempts at the top, what helps keep people in that realm of thoughts and helps us sort of mitigate the thoughts is really building on people's strengths and their coping strategies. This used to be, the vernacular used to be these are sort of protective factors, but research has really sort of strongly encouraged us not to use that language. They do not protect people from acting on suicidal thoughts if someone is in that state of imminent risk. They have no impact whatsoever. But in terms of prevention and the work that we're really trying to have the ACCS teams do, building and supporting and reinforcing both people's internal coping skills and social coping skills, resources from their community can help keep people from tipping over into that state of imminent risk. And so they are incredibly important to be paying attention to. You just don't want to make the mistake when you're assessing someone of thinking they're not at risk if they're really in that imminent state. So near the last slide that I have is just to sort of wrap this all up. Once you've done the screening, an assessment, part of what is sort of the ongoing piece of working with someone is really working with them around safety planning. And this is, RAP plans are great for this. I think people have been using the idea of safety. We've been doing safety plans for a long time, but this is really sort of encouraging all of us to be thinking about safety plans much more front and center, and as an ongoing sort of part of a preventative effort. And there's different models for safety plans, and I'm happy to talk about that a little bit more. This was supposed to be sort of a placeholder for just a segue onto a clinical example in a moment, which is, I just want to go back to the beginning also and just underscore that this is meant to be a collaborative process with the individual that you are working with. And so if you're getting really alarmed about someone's risk for suicide, that should be front and center discussed together. And so that's really what this slide is really just a reminder that often if people can just get what's in their head out, and you can really listen, that process all by itself is incredibly therapeutic and may actually shift the need from someone having to go to the ED and be hospitalized to working on a different plan that might involve respite and partial, which is so different. In terms of a clinical example, I just thought I'd put one out there and then sort of open it up for discussion. So I was just thinking about a gentleman that I have worked with in the past who, so white male, 34 years of age. When I met with him, he answered, yes, he's had thoughts about wanting to die. Yes, he has thought about wanting to kill himself. He has not in the last 30 days had thoughts about how he might do that or had the intention of doing it or had a plan. And I just want to underscore, it's important to ask all three of those questions. If the person says, yes, I've had thoughts of wanting to kill myself, even if they say, no, I don't have a method, you should still ask about intention. You should still ask about a plan. So a caveat. And he's had no behavior in the last 3 months, but 10 years ago, he had a suicide attempt that was extremely lethal, where he basically took a knife and sliced himself, and really only very fortunately did not die. And so I think what's important about that is that the Columbia, so based on the Columbia score, right now, he would be considered low risk. He would also, I think, based on kind of the severity of his attempt, even though it was 10 years ago, he's gonna have, if he's new to you, the first time you meet him, you're gonna feel anxious. And so the purpose of the Columbia is to try and hold your anxiety and encourage you to not ignore that anxiety, but also not, so it's sort of a balance of not overreacting, like, we've got to get them evaluated by emergency services immediately. So you don't want to overreact, but you don't want to underreact. So he's someone we're going to pay careful attention to and notice, based on a more comprehensive psychosocial assessment, is he isolating? Are any of his psychiatric symptoms escalating? We're going to try and understand what happened in the past and what were sort of the early indicators that perhaps he was starting to really be suffering in a way that was unbearable, and we would need to intervene to do a more comprehensive assessment and figure out how to bring more services around him. But I think, so anyhow, I'll stop there and just see if there's questions, comments.
So all the lines are unmuted again. You may have unmuted your own line, but if you have any questions, please feel free to either ask them or type them into the chat box.
I think Carol did send the updated PowerPoint that we just saw out earlier this morning. So you're right, there was an earlier version that went out yesterday, but everyone hopefully got the updated version from this morning. I think as I understand it, the purpose of these webinars is really just to lightly familiarize you with the tools that we're encouraging the ACCS folks to be using. The other thing that I have been thinking about is, in talking with some of the area directors, one of their ideas has been, as part of the area kind of risk review process, sort of when you're reviewing critical incidents or you're doing a clinical review, that one of the things you might be thinking about, and I would imagine you're sort of thinking about this with all of the different assessments that we're asking people to do, I think getting really curious about whether or not, was the screening tool done, was a comprehensive, when there's a critical incident where there's been a suicide attempt. I had the privilege of attending a area risk meeting a couple of weeks ago, and I think we looked, making these numbers up a little bit just because I can't remember exactly, but there were like 11 critical incidents that had happened, and 8 of them might have involved some kind of self-harm, self-injurious behavior. So you all are dealing with this all the time. So a thought is, really looking to see, once ACCS is up and you can feel more confident that more people have had the assessments that we're asking the teams to do, really trying to look and see whether the assessments have been done and whether they had identified that this person was at risk, what they were doing to try and mitigate that risk, and whether there's anything else that all of us, and I'm sort of doing that, that could have been done to mitigate the risk. And if the assessment tools didn't detect that this person was at risk, is there any way to understand that? What does that mean? And was there any other sort of indication that might have been helpful? So I think really using our systems for how we interact with the ACCS providers and the ways that we collaborate with them around risk management, I think having a grounding in kind of what the tools are and what information might be available, and then really trying to see if they're making use of the tools. I think the other thing, that if you want a more extensive sort of training, one of the things that is really widely recognized is that the commitment to a new tool or a new behavior is really hard to kind of gain. And so I was just at a presentation last week where someone was talking about rolling out the use of the Columbia in emergency rooms, and it, within the first month or two of training all the staff and rolling out the use of the screening tool, they found, I think it was more than 60% of people were not actually completing the tool correctly. And so it's really important, sort of another way of thinking about kind of how to use the information from today is also to think about sort of contract management and really working with providers around how they're evaluating whether or not the tools are being used correctly and implemented effectively. And that kind of circles back to the whole question around